right. Hello and welcome to the Made Fitz Show. I'm Dr. Fitz, and I don't have my co-host today, Melissa McAllister, with me. It's just me, but I'm really excited about today's interview. I have the one and only Dr. Michael Twyman, who I met at a business conference in Vegas. And for those people that are watching on YouTube, they already see your glasses, but this is what attracted me to you. You had the blue blocking glasses on. So I had to bring my own. And of course, you already told me I should be wearing them all the time. I don't, but at this business conference that you and I met at in Las Vegas, we sat next to each other just serendipitously. And I do believe that we were supposed to cross paths because you are like the only preventative cardiologist I've ever met. And, and you have the same passions that I have in giving people all of the tools so that they don't end up on your OR table in the cath lab, just like I didn't want them to be in my OR table as an anesthesiologist. So can you tell the audience a little bit about yourself before we just dive deep into all of the questions? Because I have a ton of them.
Sure. Well, first of all, thank you for the opportunity. And I agree. It was, either kind of, quantum entanglement. There was a reason we sat by each other at this business
100%.
And it's obviously just a small world. We're starting to know more and more people that we interact with. But, I'm, Dr. Twyman. I'm a board certified cardiologist in St. Louis, Missouri. This is where I did all my original training. Was an invasive cardiologist for many years. Took care of a lot of sick people in the cath lab and the ICU. Unfortunately, seen many people pass away from their cardiovascular disease. And I really got passionate about trying to do something a little bit more proactive. So went down the rabbit hole, initially discovered functional medicine probably back in 2013, 2014, so 10 years or so ago. And then really fell down the rabbit hole hard, learning about how to do advanced biomarker analysis, how to test for endothelial dysfunction, which is the lining of your arteries. And then in 2017, that's when I stumbled upon the biohacking world and thus the blue blocking glasses. The quick impetus was that I was traveling to Asia. It was a 14-hour flight. I knew the jet lag was going to be really miserable. And somebody wrote an article that said, like, if you wear these glasses, the jet lag won't be so bad. So I wore the glasses on the plane. Had some jet lag, but it wasn't that bad. I was like, that is crazy. And then when I got back, read all about circadian biology that led me to kind of the world of quantum biology, like how does light interact with your mitochondria? And then 5 years ago, almost to the week, I launched Apollo Cardiology here in St. Louis, where I could just focus on proactive preventive cardiology.
And Apollo Cardiology is literally one of a kind. Like there isn't any other practice in the United States like yours, correct?
There's some preventative cardiology practices out there, but I don't think any of them really weave in the kind of the biohacking, the health optimization, and definitely the quantum biology aspect as much as I do.
So when would you say was the moment that you actually swallowed the red pill and left the matrix?
It was kind of a process. I was in the cath lab and we were seeing the same people come back 6-9 months later and getting stented in a side branch. And we're like, but man, the patient was on their aspirin and their statin and their beta blocker and their ACE inhibitor. And we told them, eat healthy and, move more. And I was like, what are we missing? And so I think it was just that kind of wake up that, traditional medicine is great. When you're having a heart attack, we can save you, but we can't necessarily prevent you from keep coming back.
Right.
And so that's when I had a family member had some issues with some gluten sensitivity and some dietary change that it got better. I was like, well, that's interesting because I didn't learn that in my fellowship that we could talk about nutrition to that level. And so then that's when I kind of found the A4M, led me to like Dr. Mark Houston, who has been a great mentor. And I really opened my eyes at that stage.
Nice. So then the decision to actually leave the world that you were in and actually prevent them from actually needing you, how did that look? Like, that's kind of a huge leap of faith, right?
Very much so. Because as you know, it takes 10 years of training after college to get to where I was at.
Yeah. So, a lot of training.
4 years medical school, 3 years internal medicine, 3 more years of cardiovascular fellowship. And so you want to use the tools that you just learned. And so I was in a traditional group, for 4 years. And then kind of the hospital system kind of, let's just say, imploded. So I ended up joining a big group in the area that's, multiple, 15 or so cardiologists, bunch of nurse practitioners. It was a machine, but we were rounding at 7-8 hospitals. We were just, nonstop, churning through patients.
Yep.
I was like, there's got to be a better way. And I was really interested in, this preventive side of things, but it takes time to educate people. I was like, this system is just not going to work well for me and my patients.
No.
So started looking for some business mentors, and I was like, okay, I think I can do this. But I still drug my feet for probably at least a year before I said, all right, that's it. I'm out. Pulled the ripcord. I'm not going back. And I launched the practice in August of 2019, and I never looked back.
So I told you when I met you last week that I think I'm going to send my dad to you. So people fly in from all over to come see you in St. Louis because you only at this moment only have one Apollo cardiology practice, but we know that there's going to be multiple in the future. That's I'm going to speak that into you. But you already know. But if my dad, let's say, were to come and see you, can you walk the listener through like what that looks like? Because you are a cash pay only. And again, my listeners know that if health insurance is just like home insurance, and if you get hit by a hurricane or tornado, you're really happy you have that home insurance. And same thing goes if you have a heart attack, your health insurance is there. But to upgrade your house, your home insurance is not going to pay for those new floors and all of the upgrades, and same goes for anything preventative. It's an investment. So you are a cash-based business only. So we don't have to talk about the price, but if a patient decides, okay, yeah, this is totally worth the investment, they come fly to you or see you local there, walk us through what that looks like.
So I do like how you said, you have to invest in your health. Your health is really the best asset. It's the only asset that matters. If you invest now, you get the health span that you're wanting. You get to do the things you want to do in your life. Longevity is a great goal, but you want to have a good time along that route. I would sometimes joke like, if you don't invest now, well, when you get sick, you're going to be spending a lot of your funds trying to get your health back.
So true.
So a lot of patients understand this, and that's why they're kind of willing to invest with us. And so we do a 2-part deep dive. So the first visit is here in St. Louis. We do head to toe cardiovascular screening. So we're looking at the 60,000 miles of blood vessels you have. Traditionally,
you
most
just said
patients,
60, right? 60,000.
60,000.
Yeah. Okay. That's a lot of mileage.
A lot of mileage, and you got to go looking for it. Because in the traditional world, you usually don't go see a cardiologist until you're having symptoms. So if you're having chest pain, shortness of breath, exercise intolerance, palpitations, then you go get checked out. But you're pretty late to the game at that point. I'm trying to find people 10, 15, 20 years before they have their first symptom. So there's novel tests that you can do. So kind of from head to toe, we have a test called the carotid intima-medial thickness ultrasound. Okay. So we're looking for inflammation in the lining of the arteries. We're looking for soft plaque in the carotid arteries. We have a device that looks at your arterial elasticity. So in your world, it used to be in the OR, pulse ox. So we're looking at your heart rate. We're also looking at how fast the blood goes into those arteries in your finger, expands the arteries, and then they snap back, kind of like an accordion. If you have elastic arteries, less likely whatever's floating through your blood sticks to your arteries and causes plaque. We have a device called the endopath that looks at nitric oxide availability. So how well can your arteries release the gas that dilates your arteries? Nitric oxide is critically important at vasodilation. For guys, ED equals ED. If you have erectile dysfunction, you often have endothelial dysfunction. So we're testing people for their endothelial function. Normally, arteries should triple in size with this type of test.
Okay.
There's a test that looks at, do you have an abdominal aortic aneurysm? More common in people with family histories, smoking, hypertension.
Right.
Then going downstream, looking at your legs. So we do a smart ABI, so it's measuring the blood pressure in your arms versus your legs.
Okay.
And this is, would it likely have an occlusion in one of your leg arteries? We also have some fancy blood pressure cuffs that can kind of look at your central aortic blood pressure. And then we send patients out for some advanced cardiovascular labs. We draw them here in the office. Okay. We draw the genetic profiles as well. And that some of those tests can be covered by insurance. So we're mindful if people have a certain insurance, I'll cover the labs. We'll steer them in the right direction for that. Okay. Often the results take about 10 to 14 days to come back. And when they come back, then we complete the 2-part deep dive. And that's where we really kind of fine tune their lifestyle, their nutrients, their supplements, and any medications that they're going to be on.
So is it safe to assume that if a person is coming to you, they're already kind of ahead of the average American? They're caring about their, their diet, lifestyle, and whatnot. So how much of how much new stuff are you bringing to them that they're not already doing? I mean, is it pretty different as far as, when you first get to them to after looking at all of the tests and like, oh, they're living completely differently?
Many of them are already, down the rabbit hole of, optimizing their nutrition and their exercise. But I kind of open up their eyes that how important light is, circadian biology, prioritizing sleep, how to use photobiomodulation to optimize your mitochondrial function. Some of these patients know this stuff. Other people, this is the first time they've ever heard it. And so I
Right.
kind of weave that story in for them. But that's what I feel our job is to educate the patient what's going on with them. Because once they understand that, then they're more empowered to actually take steps and doing things that can actually reverse the disease. It was never very satisfying to me to like walk into a room after a person had a heart attack and like, here's 10 meds. These are for you
Right.
for the rest of your life. And like, why do I gotta take them? Like, just cause. I want to
Right.
explain how they develop that plaque and what they can do to not get it the next time.
So is there ever a point where it's just too late to come see a person like you?
If you're on hospice, probably I don't think I can save you
Okay,
at that
fair.
point. But
Fair.
no, not typically. We've taken care of patients who are very sick. Have had bypasses. People had one person near towards getting transplant, but for the most part, it's people who are more proactive and aren't that far down the rabbit hole just yet on the vascular disease.
Well, of course, the first day when I met you and I heard actually what you do, I told you, I'm like, I have literally been looking for someone like you for the past year because I've started checking LP little a in all my patients. And I guess in theory, you probably shouldn't test something that you don't know really what to do because it's out of my scope of practice. And I always tell patients if they have a high LP little a, hey, this is out of my scope of practice, but I always tell them the same thing. I give them reference to a couple of books to read. I give them a couple, like a cardiologist that has a few YouTube channels. And then I let them know, you should probably find a preventative cardiologist, but it's not going to be easy to find. And they're probably going to look at you like you're crazy because you're young, but I don't know. Like praise the Lord, I don't have LP little a that's super elevated. And I don't have a strong family history, but if I at 44 years old had a high LP little a, if I came to you because my functional medicine doctor said, hey, you should probably go see someone like Dr. Twyman, what are you going to tell me?
So first off, LPLA is present in up to 20% of the population.
Okay.
LPLA is a lipoprotein. So it's a
Okay.
lipid protein carrier. So cholesterol is a waxy compound that floats through your blood not very well. So the body wraps it up in these lipoproteins. And so for those that are watching, I always use an example of a tennis ball is a lipoprotein. So the cholesterol goes inside, the triglycerides go inside, fat-soluble vitamins, and things called phospholipids, which are building blocks for the cell, all go inside these cargo ships. So you can think of like an LDL particle is a tennis ball, and LPA is a baseball. And the pressure that the blood is going across your arteries is how hard those things are hitting your artery walls. And so a baseball, LPA, is more likely to get into your artery wall and cause plaque than just an LDL particle.
That totally makes sense.
Yeah.
That's like the first time that's ever made sense for me, and I'm a doc. Okay. So I have high LP little a. What can I do?
So there's nearly 400 risk factors that can cause plaque in the arteries.
Okay.
At this point, there are not great treatment options to lower LPLA. The really only one that works is apheresis. It's kind of like dialysis for your blood. It's not very common in the States, and not too many patients are going to sign up to go to the hospital a couple of times a month to get their blood spun down. So the only thing that really has any significant effect at lowering LPA is the PCSK9 inhibitors like Repatha and Praluent. They're only going to lower LPA maybe 20 to 30%. Nobody knows if that's necessarily that clinically significant. But there are drugs in development. Yeah, but
and
there are
those are
drugs.
expensive drugs, right?
They're about $500 a month if insurance doesn't cover them. And insurance won't be indicated just to lower LPLA. You got to have another indication for why you're on these medications. But there are drugs in development, these antisense oligonucleotides and small interfering RNA molecules that are going to lower LPLA by 95, 99%. They wipe it out. They basically go into the liver, shut off the liver's ability to make the lipoproteins that have the LPA tail on them. They're in phase 3 trials right now and are likely to come out in the next year or two. So people just have to hold on. But in the meantime, you just try to treat all the other risk factors. Lower the LDL particles, get your ApoB goals down on the LDL particles. Make sure you're not insulin resistant. Keep oxidative stress and inflammation low. Optimize nitric oxide. There's many things you can do to kind of protect the lining of the arteries. If you do that, then the LPA has less likely that it's going to stick to the artery lining. Because I have patients who have LPLA, they have no significant vascular disease. And I have people who've ended up getting aortic valve replacements, because that's also the big concern. LPLA can damage your aortic valve, and the valve may need to be replaced sooner than later in people who have high LPA levels.
Okay.
But in my practice, I been checking LPA since probably 2013. So I have hundreds of patients who have high levels of LPA. There's still things you can do to tell people, is it likely LPA is actually a problem? There's a couple labs you can do. Most of the time, you have to do the specialty labs with either Boston Heart or
Okay.
Cleveland Heart to get these numbers.
Right.
But you can look at an enzyme called LPPLA2. It's
Okay.
also known as the plaque test. If that enzyme is elevated, then LPA is probably very high and also probably actually getting stuck in your arteries because that enzyme gets higher when there's more plaque in the arteries.
Okay.
Interleukin 6, when interleukin 6 is high, it actually raises your LPA levels.
Okay.
So this was something that was common when people had certain viral infections. It would raise these interleukins, LPA would go up. And then there's something called oxidized phospholipid ApoB. It's a mouthful, but if that type of cholesterol particle is elevated, that's basically the cargo that the LPA particle is transporting around in your blood vessels.
Okay.
If the LPA particle now gets trapped in your artery lining, it's like bringing toxic waste into the artery wall. And then that just causes this big inflammatory response in the artery walls, and the plaques really kind of take off at that point.
So is it safe to assume that the higher the number on your LP(a) lab value, the worse off you are?
For the most part, yes. The more LPA particles you have, the more atherogenic or plaque forming it will be.
Okay. And my understanding, not being a cardiologist, is that really diet and lifestyle cannot really affect the LP(a) at all. Is that correct?
That is correct.
Okay. Okay. So I have seen a few patients that I've rechecked it and it has gone down. It's never in normal limits, but let's say that it was 98 when I checked labs 6 months ago, and I just rechecked it, and now it's like 68 because they've been doing all of the functional medicine and mitochondrial hacks and all of that kind of good stuff. So that's better, but still not possible to get down in the green zone, if you will.
Probably not. You know, the two bigger levers that will have some effect on is like keeping inflammation low.
Okay.
And then in your world, it's estrogen replacement therapy. So you will tend to see LPA increasing in perimenopause, menopause. And it's not an indication for somebody to go on HRT. They got to have another reason to be on it, but you often will see the LPA coming down with estrogen therapy.
So you're a fan of estrogen therapy, yes?
I treat many women, who are on hormone therapy, and have been seeing it, do that for about 8-9 years. So I have no concerns for women who are appropriately, screened and treated with bioidentical hormones.
Perfect. Are there any other bioidentical hormones that you're a fan of females taking for preventative as far as just cardiovascular health?
Maybe not so much for just preventative, but obviously progesterone can help some women who have not so great sleep, waking up in the middle of the night. Top of mind for me, it's either it's a circadian rhythm issue and their melatonin levels are very low, or they got a progesterone issue and get on some micronized progesterone and often their sleep improves. And then testosterone, women obviously make some degree of testosterone, but it's often deficient at some stage of their life. And then it's harder for them to hold on to their muscle mass. And once their muscle mass starts going, their metabolism goes, their libido goes. So optimizing testosterone, indirect ways, so healthier muscles, generally healthier, cardiovascular system.
So one thing that I thought was interesting when I was talking to you in Vegas was that one of your first priorities is the circadian rhythm and the sleep-wake cycle. Can you talk more about that for me, please?
Yeah, I mean, for the people who haven't necessarily, gone down this kind of a pathway before, there's a great book, from Dr. Sachin Panda, the Circadian Code. You read this book and you'll come away with the idea like it can't be this simple, but it is. The time that you eat your meals is just as important as what you actually are eating. The food is energy and information. It's telling your body, is it daytime or nighttime? Your body's always craving, basically setting its clocks. You have something known as the supracosmatic nucleus. It's behind your eyes, and it's getting signals of light through the eyes and telling the body what time of day it is. So before they invented light bulbs in the late 1800s, the only light you had was sunlight or fire. And so most people would have gotten up around sunrise, and that would have been the first bright light they got in their eyes. There's a receptor in the eye called melanopsin. It's essentially a blue light detector. And so the sky changes color throughout the day. And that color temperature blue tells your body it's morning time, it's noon time, the sun's about to set. And then when the sun sets, no more blue photons of light hit that back of that eye. And the body knows, oh, it must be nighttime. And it sets a clock, and you usually go to bed 3 to 4 hours after that time. But modern technology being what it is, it's great that we can communicate across many miles, but the color temperature coming off these devices from the screens is set at 5,500 Kelvin. It's basically telling your brain it's noontime every time you look at these devices, or if you turn on the artificial lights, which in my office, I rarely ever do.
Right.
So I want to always tell my body what time of day it is. So I go outside in the morning, right when the sun's rising, get 15, 20 minutes of light in my eyes, usually go for a walk, go inside, and eat within the first hour of when the sun rises. Just trying to set those clocks. And then anytime I'm inside and I'm not controlling my light environment, I just have a pair of glasses on that filters out some degree of blue light from reaching that melanopsin receptor. You still want some blue light to reach it because you want your body to know it's daytime.
Right.
Then post sunset, my sleep cycles are so dialed in, I don't have to do it anymore. But there's darker glasses that'll block 100% of blue light, 100% of green light, and they just knock you out. I'll be asleep in half an hour using those things. So I will use those still if I'm traveling a lot eastward and have to kind of get set up to the new time zone. But if you keep your environment very dark at night, your sleep tends to improve and your melatonin levels will remain higher. And melatonin is the master hormone that's repairing your mitochondria while you sleep. So it's critically important to have healthy mitochondria. I'm a cardiologist. Yes, I'm caring about your 60,000 miles of blood vessels, but in my office, I have a giant mitochondria on my wall,
I noticed
which
that.
I point, which I
I was
point to my
wondering if
patients.
we were going to talk about that.
Yeah. So I, tell my patients like, yes, you probably came to me because you have quote lipid issues. We're going to talk about that and we're going to fix them, but we have to talk about your mitochondria because if your mitochondria aren't doing well, you're not going to do well long term. So, your circadian rhythms are what really help program the mitochondria.
Okay. So if we want to have the healthiest mitochondria, obviously we need to get our circadian rhythms in check. What are some other things that we can do?
It really comes down to not damaging mitochondria with things like non-native EMF. So Bluetooth, Wi-Fi, cell phones, all those things cause cell danger responses to the mitochondria. It causes inflammation inside the mitochondria. Eating food requires the mitochondria to process it. You're going to make basically smoke or free radical damage, when you're combusting oxygen with the carbohydrates and the fats that you're eating. So the mitochondria, need to be able to be repaired when you stress them with either eating or when you're exercising. If you don't repair them, it's kind of like having an engine where you've never changed the spark plugs. And the next day you're expecting to put in this super premium organic gasoline food, and you're expecting the engine to still go 200 miles an hour. It's not. So a lot of times with mitochondria, it's about withdrawing things that are damaging it more than actually putting supplements in or doing things to try to improve it.
That's what I was literally just about to notate because I didn't hear you say, oh, you can use XYZ supplement to help the mitochondria. It's more of removing the crap that is injuring them. And I mean, we live in America and that's all people do, right? So can we look at a lipid panel? Because this is a common question. And, I screenshotted and sent you all of the questions and I definitely want to get to a few of them, but a lot of them did have to do with LDL and HDL and triglycerides and all that kind of stuff. So can you give me your generic explanation of what you really care about being a preventative cardiologist?
So I always tell patients, you got to kind of look at two things. You got to look at the biochemical. So that's going to be the labs. That's what's floating through your blood.
Yeah.
But be mindful, that's a snapshot in time. What you want to really know is the biophysical. What are your arteries doing with what's floating through the blood? Because there are people who have, quote, normal cholesterol that still have heart attacks. It's still a fact that about half the patients that come into the ER with heart attacks have normal cholesterol.
Correct.
Cholesterol is always going to be in a plaque, but it's not the primary thing that drives most plaques for people. So that out of the way, when you're looking at a traditional lipid panel, it really doesn't predict risk that well unless your total cholesterol is over 300 milligrams per deciliter.
Okay.
Your LDL cholesterol is over 190 milligrams per deciliter. In that instance, that's the phenotype of FH or familial hyperlipidemia.
And
so
that's when you get worried.
That's when you get worried. The person probably has a gene that's really causing their lipoproteins to be very elevated. On the traditional lipid panel, you'll also see your triglycerides and your HDL cholesterol.
What are your goals for those numbers?
Triglycerides under 80, HDL cholesterol, no goal. There's no data to be doing anything to try to adjust HDL. Now, if your HDL is low because you're completely sedentary and you get into an exercise routine, your HDL cholesterol goes up, good for you, but you're getting other benefits from the exercise. It's not necessarily that the HDL goes up.
Makes sense.
HDL is extremely complicated. it's way more complicated than high HDL.
It's not just the good cholesterol is what I'm hearing.
There's just cholesterol. There's different lipoproteins that take it around, but there's no such thing as good or bad cholesterol. You just don't want cholesterol building up in your artery walls. That'd be the bad cholesterol.
Right.
HDL has roles where it's a part of the immune system. It helps go fight infections. It's delivering cholesterol to the adrenals and the gonads so you can make hormones. And it all sometimes will get into the artery lining and be able to pull out the cholesterol from the artery lining and help reverse the plaque. But there's no guarantee people's HDL can do that. If they have high myeloperoxidase, which is an enzyme that's found in white blood cells, if they have a lot of inflammation, the HDL gets damaged. And then you have dysfunctional HDL. And your body has to crank out a new HDL particle to replace it. And your HDLs can be high, but it actually doesn't work. And it may actually be proatherogenic. So that's why I say HDL is so complicated these days. I don't say you should ignore it, but you should not be trying to target it on the traditional panel. Look at your triglycerides. If your triglycerides are above 80, you have markers that have insulin resistance, and go work on those. So that's the starting point for a traditional lipid panel. But it's much more about the lipoproteins that carry the cholesterol through the system. So you can measure this on an NMR panel, and it can how many particles are carrying the cholesterol through your blood vessels.
Okay.
Most of the time, you generally want that LDL particle number to be less than 1,000.
Okay.
Now, this gets a little bit more complicated, but you brought up LPA earlier.
Right.
So LDL particle and LPA, they're very similar. Now, they're both spherical, but one's more atherogenic or more likely to cause plaque.
Okay.
On the outside of this tennis ball and on the outside of this baseball, there's these white stripes or the red stripes.
Right.
That's essentially the ApoB protein.
Okay.
That protein holds these things together in a sphere, and then it acts like a little ligand or key so that when these things are floating through the blood, the little receptors can grab onto them and get them out of the circulation. If you count up all the ApoBs, then you count up all the particles that potentially could stick to your arteries and cause plaque.
So you don't want a lot of ApoB.
You don't want a lot of ApoB. Most people should be shooting for an ApoB target less than 70. That would put you at about the 20th percentile, meaning 80% of people will have values higher than you. You tend not to build up as much plaque in your arteries when you're in this lower percentile.
Okay. So what can we do to get our ApoB less than 70?
That's a great question. So always starts with, auditing the person's lifestyle.
Of course.
So you want them to be doing their cardiorespiratory training. You want them to be doing their strength training. But that being said, it doesn't have a ton of, effect on the lipoproteins. There's so many gene interactions that have a bigger effect than what your exercise is going to do.
Okay.
But nutrition does have a pretty decent role.
All right.
If you're insulin resistant, you have to reverse that, because if you're insulin resistant, you're going to crank out a lot more triglycerides often. When you make out a lot of triglycerides, you're going to tend to have a lot of VLDL particles. And those VLDL particles, they break down and they become more LDL particles. So fix the triglyceride issue, you'll tend to make less ApoB particles downstream. The fat side of the equation is a little bit more tricky.
Okay.
Some people are sensitive to saturated fat, other people are not. Sometimes it comes down to your ApoE allele.
Okay.
Echo. If an ApoE4 allele, sometimes those higher fat diets tend to cause a lot more issues with the lipoproteins. But some people can have an ApoE4 allele and be eating a keto carnivore diet, and not much happens to their lipids. So it's one of those cases where I tell people, I'm from Missouri, you got to show me, you can change your diet, but if your lipids go through the roof, you got to show me that you actually have healthy arteries on that type of diet.
Right.
Otherwise, I tell you, you got to switch up the diet, or you're going to end up on medications to treat the lipoproteins.
So if I have a patient that I've tried to dietarily and lifestyle get their ApoB down, it's down less than 70, but it would be beneficial to actually come to you and get some more invasive tests to see on the vascular level what's going on. Am I hearing that correctly?
Right, because it's not all about cholesterol. So you want to know, do you have healthy endothelium? And that's really the starting point for vascular disease. So lining your arteries, you have something called the glycocalyx, and underneath that, the endothelium. It's a protective gel coat, or think of it like a force field. Okay. If that coating is healthy, whatever's floating through your blood tends not to stick to your artery lining and get into the artery and kick off a plaque formation. But if the endothelium gets damaged, all bets are off. And you can start having endothelial dysfunction in your teens and 20s. You still have time to intervene, but if you don't fix it, then that's when people start laying down enough plaque that they start showing up to the hospitals in their 50s and 60s. So endothelium is something that can be damaged easily, but it's, again, one of those things that if you get the things that are damaging it out of the way, the endothelium and the glycocalyx can repair itself. Unfortunately, there are other supplements that can help support it if you, can't absolutely get it up with just lifestyle interventions, but you have
Right.
to be able to test, is the artery lining actually elastic? Is it actually able to produce nitric oxide? And that's what you really are looking for when you're doing these type of testing.
So I'm going to ask you a question that I already asked you when we were in Vegas, but I know that listeners are going to be interested in your answer. Can you tell me what supplements you take daily?
So what do I personally take? Again,
Yes,
this is my own N of one.
of course.
So, I mean, I probably should take a quick sidebar on it, is that, obviously I'm a proactive preventive cardiologist. I've been a biohacker since 2017. So I've done a lot of things, and I'm very interested in longevity. I had a grandmother live to 106 years old. I'm trying to beat her record. After a while, I was actually able to figure out the genetics that she likely had, because she was one person who never went to doctors. She did not take a medication, and she lived alone until she was 100. I would not necessarily want her last 6 years, because she did die with dementia and, approximately from pneumonia. But, what did she have? Well, my dad and a couple of my siblings, their lipid profiles are, they got what's known as hypo-beta-lipoproteinemia. Fancy word is
Okay.
super low cholesterol.
Okay.
So my dad's ApoB is 43 with no medications.
Wow.
He has an ApoE2 allele, which is cardioprotective and also, a marker of longevity. But he also has what's known as a loss of function PCSK9 gene.
Okay.
So without PCSK9, you can't break down the docking stations that are plucking out the ApoB particles. So essentially, it's like built-in Rapatha. So they
Nice.
have very little, atherogenesis on that side of the family. My mom's grandma, or my mom's mom, my grandma, she's
Right.
a smoker. She would have had LPLA. I don't have it. She also had something known as SCARBY. Her age still did not work. So she developed vascular disease in her late 40s. She had cardiac bypass surgery in her early 50s. She had strokes. She had carotid endarterectomies. She had FIMPOP bypass surgeries, and she died at 63 years old from a stroke.
Yeah.
It's like, okay, bad genes on that side. Smoking.
Which genes do you have?
I'm a mix. And so I don't have the worst. I don't have LPLA, but I don't have the ones that drop my ApoB to 40s without help. So my natural resting ApoB is probably in the 50th percentile, probably 100, 110.
Okay.
But all my other markers on these advanced testing, stone cold normal. Carotid intimal thickness test, normal. Normal vascular age, actually under my biological age. No plaque.
Nice.
Calcium scores of 0. No hard plaque in the coronary arteries. Did a CT angiogram. Read as normal by the radiologist. Sent those images to Clearly, which is a AI company that uses machine learning to analyze the images.
Right.
They found more plaque than I wanted in some arteries. And I was so pissed off when I saw the report. It wasn't even
I
funny.
would have been too. I would have been too.
But I talked to their team and I was like, okay, I understand. This technology is so sensitive that we're going to find plaque that we could never find non-invasive.
Right.
We would have found it with, IVUS cameras if you're in the cath lab, but you don't end up in the cath lab unless you have symptoms or you fail the stress test.
Exactly.
So this is going to be the first time you can find the walking well who have plaque in their arteries and had no idea they had it. So once I knew that information, I was much more aggressive with my regimen. So my theory is that you have to protect the glycocalyx and the underlying endothelium first. Think of it again as like the force field. If you keep your force field up high, less likely the lipoproteins are going to be damaging the arteries.
Yeah.
So I took a product called Vascanox to support nitric oxide and hydrogen sulfide. That helps dilate the arteries. I took a product called Arterosil, which is a glycocalyx promoter. So it has basically building blocks to regenerate the gel coat of your artery lining. So
Nice.
the force field. I took
That's a product by Orthomolecular, right? If I remember correctly.
It's from a company called Calroy.
Okay. All right. I remember correctly.
And then I took Kyloic age garlic because that has been shown in studies to help shrink softer plaques and stabilize them.
Okay.
And then I was playing around with a couple of different things to try to modulate lipoproteins. I was taking bergamot, which is a weak HMG coreductase inhibitor. So it works kind of like a statin, just not as strong.
Right.
And then taking berberine, which acts somewhat like metformin. I wasn't taking it for that reason, but berberine is also a weak oral PCSK9 inhibitor. But doing that round, it didn't really have much effect on my lipoproteins, but I ended up repeating my Clearly scan 2.5 years at the initial one, and the plaque had shrank 6% in that time.
Really? Okay.
No pharmaceutical agents. And so I was like, interesting. So they're going to have to do more studies. That's my N of one, but it at least proved my hypothesis that if you keep the glycocalyx healthy, you're not going to continue to do damage.
Right. Makes
Since that
sense.
time, I've decided to take a pharmaceutical. I decided to start ezetimibe to try to lower ApoB a little bit further. And then at some point, I'll repeat a clear scan and show myself that I continue to shrink that plaque down.
So when is a patient really due for a statin? Because I know that there's a lot of controversy, and especially men versus females too, right? That's a
Correct.
common question I get.
I get it every day as well. It's
I
the
bet.
most common question I get. So I decided that, statins are tools. They should not be in the water. We should not all be on them, but they're also not poison where nobody could benefit from them.
Right.
Now, it's not very controversial to say that, secondary prevention is useful to take these medications. If you've already had your chest cracked open, you've had bypass surgery, you've had a stroke, you have stents, having a statin on board has been shown to reduce the risk that you'll have that happen again.
Okay.
The people that are kind of more in the what should I do are the primary prevention people. They've
Right.
never had an event and they're being told your cholesterol seems high. Here, you should take a statin to lower this.
Right.
This is where it gets a little bit nuanced because honestly, I think of it as something as primordial prevention, primary and secondary. Secondary is easy. They've already had their events or you've done enough testing to say, wow, they got a lot of plaque. We got to put these fires out by throwing the kitchen sink at the people.
Right.
But classically, what we're calling primary prevention, people who have never had an event or symptoms, they may have not done enough sensitive tests to actually go find it. If I did a clearly test on every single person out there, I would put a lot more people into higher risk categories.
Totally.
So primordial would be that, you're very young, you have absolutely no plaque in your arteries. Okay, great. Those people are not likely to benefit right at that point. And so you're wanting to treat the plaques. You're not necessarily cared so much what's floating through the blood. You're just trying to stabilize the plaques from rupturing because that's the name of the game. That if somebody builds up a significant plaque in their artery, they're going to get short of breath, chest pain, exercise intolerance. They're going to get picked up by the traditional system.
Right.
More than half the time somebody has a heart attack, the plaque is less than 50% occlusive of the lumen. So meaning the blood can flow through the artery, the patient can't feel it, and they have no idea this plaque's there until this plaque ruptures. It's kind of like a volcano or a pimple. It pops, the blood clots. Now you got 100% blockage. You're on the way to the cath lab if you're lucky.
If you're lucky, yeah.
And so those people, the statin is stabilizing that plaque, trying to put a thick cap over the plaque so it doesn't rupture. Those people, it's not questionable. But going back to your question, you would do a biochemical and a biophysical assessment on this person. The biochemical, yes, we do the traditional lipid panel. We would look at the lipoproteins. We look at ApoB. But you can do other testing that can look at, are they a hyperproducer of sterols? Or are they a hyperabsorber of sterols?
Okay.
If they're a hyperproducer of sterols, then statins will tend to work better for them. If they're a hyperabsorber of sterols, ezetimibe tends to work better for them. So the analogy I tend to use, I came up with it on my own, is think of cholesterol as water going into a bathtub.
Okay.
Don't want the water to overflow.
Right.
How do you prevent it from overflowing? You can reach in there, dial back on the faucet. That'd be like using a statin to dial back how much cholesterol is being produced in the liver.
Okay.
You could open up the drain in the bathtub. That's using PCSK9 inhibitors, or Preluent, Ilisclerin. Open up the drain, get the water out. And then once the water's in the drain, you got to make sure it gets out to the sewer. Some people have an issue that the sewer is basically blocked and then the water backs up.
Right.
This is where ezetimibe is used. The ezetimibe opens up the blockage, lets the water leave, because that's how cholesterol leaves the body, is through the GI system.
Right.
So you can kind of look at these labs and figure out which medication will likely work best for that individual.
So why are all cardiologists not doing this?
They're not educated to read these labs as well yet.
Okay.
And a lot of this is not shown in randomized controlled trials that they're used to looking at. It's more like, this is what's happening in this one individual in front of you. And so that's what I'm trying to always do, is treat the individual in front of me. In a population, statins probably work, but some people they're not going to respond to. Right. And I know your audience is probably more, physically active. That is the biggest challenge with statins, is that some people have muscle symptoms that prevent them from being able to do the activities that they want to do.
Right.
Now, it may be, the trials is, I think they say it's like 8 to 9% of people have muscle symptoms. So muscle pain, weakness, those are the kind of the symptoms that people have. Very rare, very rarely is it rhabdomyolysis where the muscle breaks down. But in clinical practice, it might be a quarter to a third of the patients have some type of muscle symptoms, especially when you get to the higher doses of the statins. So often
Right.
I'm using low or moderate dose if I'm using them at all and using something else synergistically with them. But like even in my own example, there are certain genes that people will tend to have a lot more muscle symptoms with statins. So if you have an SLCO1B SNP, you got a 4 to 5 times increased risk of muscle symptoms on statins. That's the reason I decided not to start that first on myself. If you're an ApoE4 carrier, they don't tend to respond very well to the statins. Their lipids don't improve very much, and they tend to
Okay.
get more of the side effects.
Okay.
And classically, if you're vitamin D deficient, if you're hypothyroid, if you have low CoQ10, you're almost assuredly going to have muscle symptoms. You have to fix those things first.
Right. Right. Which that you've just described probably 98% of the Americans, right?
Right.
So so my dad is actually someone who got the myalgia very bad from the statins. What are great options for someone like him that really would benefit from statins, but can't because the side effects are just not tolerable?
So there's 4 pharmaceutical class of medications that have outcome data at reducing major adverse cardiovascular events.
Okay.
And that's what people care about. You don't care
Right.
about the labs look pretty on your lab report. You care like, did you have a heart attack or need a stent or
Exactly.
need surgery? And so those 4 classes are statins, ezetimibe, which is a cholesterol reabsorption inhibitor. The third one on the line was the PCSK9 inhibitors,
Right.
Praluent, and then the fourth one, which is newer, is called bempedoic acid. Its trade name currently is Nexletol. There's not a generic version of it. Nexletol is akin to a statin where it's working at the liver, dialing back how much cholesterol is being produced. But what's novel of it is that it's a prodrug and its receptors are only in the liver. So there's no receptors in the muscles to uptake this prodrug and turn it into the active form. So people don't have muscle symptoms on this medication.
Okay. Nice. What about like high dose omega-3s?
Doesn't have a major effect on the lipoproteins. It can be useful if people have high triglycerides, but you need to typically get into like the 4 grams a day of omega-3 to do that. But I will use some omega-3s to help if they have a lot of lipid oxidation. So if they have high oxidized LDL and omega-6, omega-3 ratios up, then I'll use it in those cases.
Okay. Who needs a coronary calcium scan?
Great question. Start off like who does not. So if you've already had an event, you don't need one. If you already had a heart attack, stent, stroke, bypass, you're high risk, treat that person as such. If you've already had a calcium score test and the score is not 0, it's probably debatable should you ever repeat it. Once it's abnormal, and it's likely only to get worse. It's just a matter of degree. How fast is it going to get worse?
Right.
So honestly, if you live long enough, almost everybody's calcium score is going to become positive. You just want it to be positive in your 70s and 80s, not earlier.
Right.
So I have kind of a cutoff. The traditional guidelines, I believe, is that they're saying like, 45 for a man, 55 for a woman.
Okay.
That's still too late. So I used to have just kind of a standard rule, 40 years old was kind of when I would start doing that test.
That's when you got yours, right?
I probably had one a little bit earlier than that because I was doing an experiment for a radiology group, but I had, and I expected it to be 0. So 40, kind of like, think about like a mammogram. We're looking for cancer at the earliest stages. You should look for heart disease at the earliest stages. Not a lot of radiation tests.
Right.
Unfortunately, in the past year or 2, I've seen more and more patients under the age of 40 with very high risk calcium scores. And I was very surprised by it. I had a gentleman not that long ago who was 36, had a family history of, father had vascular disease in his 50s. He's like, hey, when I'm 40, I probably should start getting screened. He was going to get a different kind of imaging test to look at, some abdominal pain, and they'd seen some calcifications in his coronary artery. And so they sent him for the formal calcium score, and the score was nearly 1400, which would put him at the 99.99 percentile for age. A calcium score over 1,000 is very high risk. And to have it under 40, it's like 5-alarm fire. Like, we have to find out what's going on with this gentleman. And so fortunately, we figured out what was going on, put out the fires, and this guy's living his life the way he wants. But he was essentially a walking time bomb. He had no idea this was going on. So now my kind of cutoff is probably 35 is a good starting point.
Right.
But I still fully expect probably, and I don't have the exact data, but probably like 99 out of 100 people are still going to have a score of 0 at 35.
Right.
But you're going to find those rare people like, oh, we have to do a lot more. And yes, 100%, this person should be on aggressive lipid lowering therapies at an early age, including a statin if they can tolerate it.
Right. But health insurance probably doesn't cover that when you're 35. Is that safe to say?
I think in this instance, because they had seen enough calcifications on the CTA abdomen, they think they were able to get it for them. But even if they don't cover it, most cities, this test is about $100 to $250
Good to know.
out of pocket for most, but it, is a test that could literally be life-saving.
So you should just go into Google and say coronary calcium score near me and find.
And in any big city, there's probably, 5-10 different imaging centers offering it. And because it's direct to consumer, sometimes they're going to have decent search engine optimization, so you should be able to find them.
Right, right. And you have one at your place, right?
I don't have the CT scanner in my place. I have one very nearby me.
Okay.
And so we just have a relationship with them and send them on over there.
Nice, because I've already planned to come see you and Amy Scuttle, so I can see both of your places and maybe get some testing from you as well. So
Awesome.
can we answer some of the questions, because
Sure.
I feel like, I mean, there's how many screenshots I showed you, a lot of questions, but I want to make sure that I do get to some of them, because a lot of them are stuff that I've heard for the longest time. So I'm going to start with does the GLP-1 reduce cardiac issues? Because everyone's talking about GLP-1s. So talk to me about that.
So in March, the FDA approved semaglutide to be utilized for the first time for reducing cardiovascular events, because a trial had shown that there was about a 1.5% absolute risk reduction taking semaglutide compared to the placebo. So they were reducing heart attacks, strokes, and deaths. But there are other benefits for patients, other than just weight loss and glucose control. It helps lower oxidative stress, so less rusting from the inside. It can help with natriuresis, so it can help people pull off fluid if they have, excess fluid. Some trials are a little bit more gray zone on, like, does it actually help heart failure? The SGLT2 inhibitors tend to work a little bit better for those, but maybe still useful to use a GLP-1 for patients with heart failure. But very interesting, and I didn't know this until recently, is that it actually does help the endothelium and helps endothelial nitric oxide synthase. So it does help dilate the arteries. So I'm going to start looking into that in my patients, because some of my patients are on it for other reasons, but I haven't really been tracking their nitric oxide levels pre and post this, but now I'm going to start thinking about it.
Nice, nice. That's kind of exciting. I have someone basically saying that she already needs to make an appointment with you. So I know that you with the connection you have with so many really well-known doctors like Dr. Gabrielle Line, I know that you have a long waiting list, but I do want to make sure that and send people to you, because I know that there's going to be a lot. Let's talk about this. Alternatives for people with AFib that don't want to go on medicine.
So atrial fibrillation is a arrhythmia, and its main concern is the risk of stroke. And so there's two kind of thoughts on this, is that, when somebody comes in atrial fibrillation, you got to figure out, like, do you have to rate control them or rhythm control them? After that decision, you have to decide, what is the risk of stroke having atrial fibrillation? There's a calculator called the CHADS VAS score. You plug in some numbers. So do you have heart failure? Do you have hypertension? Do you have diabetes? Do you have a history of stroke? Do you have atherosclerosis? Are you a female? You plug these things into the calculator, and the higher your CHADS VAS score, the more likely you are to have a stroke. Those individuals will benefit from being on anticoagulation to lower the risk of stroke. That being said, as long as the risk of bleeding does not outweigh that.
Right.
The rhythm versus rate control, it really depends on how symptomatic you are with atrial fibrillation. There's people I know that have been in AFib for 40 years, and they don't really feel that bad. You leave them in AFib. There's other people can tell you, like, it is 4:30, I'm in AFib, I feel horrible. Oh, I just popped out of it. It's 4:45, I popped out. They know exquisitely when they're in and out of it. And so that is kind of the decision, like, well, how aggressive do you have to be treating that person? If you're doing a rate control, you generally want people's resting heart rate to be less than 110 if they're in AFib. Probably you're going to push a little bit harder with calcium channel blockers or beta blockers in that instance. So that's kind of the treatment options. Now, if you're now on antiarrhythmics, I'm always going to defer to my EP colleagues to decide which antiarrhythmics best for that person.
Totally.
And then, there are patients who absolutely say, like, I don't want to be on any medications no matter what. And they're more open to doing, the AFib ablation procedures. But I always kind of give it with the caveat is that these procedures are not risk-free. There's always a risk of death, bleeding, damage to the vascular system during this case. That's not zero, but you have to talk to your EP doc about what is their kind of complication rate from doing that procedure and what is their success rate. Because what I've mostly seen is that if people are going to go for the pulmonary vein oscillation to try to treat AFib, they sometimes need this procedure twice to
Yep.
get like a 70, 80% quote success rate. So some patients will go that route. But in my world, where I'm more proactive preventive, I'm trying to figure out why the person's in AFib in the first place.
Right.
Do they have uncontrolled hypertension? Do they have sleep apnea? Yeah. Are they drinking too much alcohol? Yeah. There's many reasons why. Is their thyroid overactive? But it's
Mm-hmm.
also somewhat a marker of high oxidative stress, low nitric oxide availability. If you fix those things, sometimes they stop going into AFib. And then there are certain genes. There's a gene called 4q25. If you have that gene, you're genetically more predisposed to have AFib. So always check that
Really?
the history of it. Yep.
Huh. Okay. I'm learning all sorts of new stuff today. So, but what I'm hearing is that there's not a supplement for AFib.
Not a direct. I mean, like there's people, you can take magnesium, you can take CoQ10, but they're not going to be curative. You got to figure out
Right.
what's causing the AFib in the first place if you can.
Right. So then that leads me to my next question. So arrhythmias are common in someone who has congenital heart defects, or just a simple heart murmur that was detected in early age. If someone has a heart murmur, what is your recommendation as far as working with someone like you? How often should they see you? And as we get older, what are your kind of guidelines to seeing them?
So a heart murmur is just turbulent flow across one of the valves or the heart structure. So a doctor puts a stethoscope on your chest and hears a sound. If the valve is leaking, it's regurgitating, you're going to hear kind of a whooshing sound. If the valve is stenotic or tight, the valve isn't opening very well. And it's kind of like putting your finger over a garden hose and you hear the water going out very fast. That's kind of what it sounds like. So depending on which valve, you can kind of come up with, on your auscultation skills, is it likely mild or more severe? But if you don't have that ability to listen as well, you get an echocardiogram, and then you can measure the gradients across the valves and quantify mild, moderate, severe. And if it's more on the mild side, you probably repeat an echocardiogram every 2 to 3 years. If you're getting into the more severe regurgitation on the mitral valve or severe stenosis on the aortic valve, you're getting closer and closer to having to have valve surgery to replace that. So then you're probably every 6 to 12 months repeating this and looking very hard for like exercise intolerance, because that's often one of the major side effects of these kind of valve issues.
So is it safe to say if you've ever been told you've had a heart murmur, at some point you should be getting an echocardiogram just to see the severity of it? Is that safe to say?
Generally, yes. I mean, it depends on, age of life when you first heard it.
Okay.
Because, if somebody was told this as a child, there are
Right.
some murmurs that are, benign or not going to cause you a problem, and you quote, can grow out of them. But there are certain murmurs that are kind of more malignant. So if you have a murmur and you don't know what's causing it, an echocardiogram is a good idea to try to figure out exactly what it is. And then that can kind of quantify like, hey, I need to follow up every year for this, or, oh, okay, I have a small membranous VSD. I was born this way. I'm always going to have this murmur. It's not going to cause me any problems.
Okay, let's see. I have got a few more that I want to, because we definitely don't have time, because I just realized that we have been talking for an hour. Let's go for coconut oil as saturated fat. How important is the saturated fat in our diet as far as preventative for cardiac reasons?
I would never call it, preventative for cardiac reasons. I would say kind of alternative fuel source. You're not going to store MCT oil, but I have seen on occasion that, that is one of the biggest things that kind of quote breaks people's lipoprotein, panels. They're mixing up their MCT oil in their coffees, and they don't really account for that. And then when you kind of do a history, like, oh, I started doing this 6 months ago, I was like, that's the tie break for you, that this is why this went up. Doesn't happen to everybody. And so I can't blanket tell people like, you got to absolutely avoid it. If you're getting some mental nootropic benefit from it, cool. But just make sure your lipoproteins are staying in the range that you need them for your vascular health.
So if they're following a ketogenic diet, they need to follow those labs very closely.
Correct. And so the test don't guess philosophy. Like you can eat whatever you want, but if there's some kind of biochemical downstream effect, you're going to have to do something about that.
What are some of the most important genetic tests that you would look at just as a cardiologist? Like if you wanted to give a person like, hey, I want to go to my primary care doctor and ask for these, what would those be?
The number one be the one that we talked about earlier. It's Lp(a).
Okay.
20% of the population has it. You only need to test it for once. If you have high levels, you're always going to have high levels.
Right.
If you have low levels, there's no reason to repeat it. Now, there's some caveat that you should repeat Lpa particularly once the drugs come on the market that can lower it. But in the meantime, you need to check at least once. And then the other ones that typically will check in patients, I will always check ApoE, is echo E. And you want to know, are you an ApoE 3, 4, or a 2 carrier? You get one copy from mom, one from dad. Most people have a 3-3 allele. But if you have a 4 allele, higher risk of vascular disease, higher risk of diabetes, higher risk of Alzheimer's. Not a like, hey, you got Huntington's and you're going to get it guaranteed, but you have to be much more proactive at not becoming insulin resistant and keeping inflammation very low. And then there's a gene called 9p21 that I will check in patients. This one is colloquially known as the heart attack gene, because if you have this gene, it can double to triple your risk of having a cardiovascular event. It mostly is affecting the endothelium, the smooth muscle in the arteries. So think of it as a gene that's pulling down your force field, making it more likely your lipoproteins are going to damage your arteries.
Okay. Now, my next question is wearables. So I know Aura Ring, you have Aura Ring, iWatch, we've got the Whoop, we've got a ton of different wearables, heart rate variability. Like, what is your take on them? Obviously, you wear some of them. So what's your take on them, and which ones are good, which ones are bad, and how can we better them?
So I've played around with a lot of them. And it's really about just, sticking to one platform, because I was doing for a while doing, a ring and a band at the same time, and they were giving very different data points.
Right.
So, you can't really compare your heart rate variability on a ring to a watch.
Okay.
So that being said, pick one and keep with it. I tend to still like the Oura Ring for sleep tracking because it's unobtrusive and you don't have to think about it. But one caveat, unless I'm trying to monitor something, most of the time I have no wearables on me. I don't want any electronics on my body because I don't want the EMFs interfering with my mitochondria. So this ring is always, always in airplane mode. I record in airplane mode, take it off my finger, drop it on the charger, download the data from it.
Nice. So you don't wear ear pods. I mean, I try not to wear ear pods. I've got wires in right now, but no iWatch, no nothing.
Nope.
That's what I should do.
Anecdotally, wearing the watches, I've seen some people have some significant heart rhythm issues with it. And the second they take the watch off, the rhythm issues go away.
Really? Oh, wow. Okay.
They're using the watch to track the rhythm issues. I'm like, the watch is probably causing them.
Interesting. So what about someone's HRV? Let's talk about HRV, because that's a common question I get.
Yeah, I do as well. It's heart rate variability. It's the beat to beat difference between, consecutive heartbeats measured in milliseconds. And it's something that does vary with kind of the balance between your autonomic nervous system. So you got your sympathetic, your fight or flight response, your parasympathetic, your rest and relaxation response. And so when you're breathing in, your heart rate increases. When you breathe out, your heart rate goes down. So does your heart rate variability. It kind of expands and contracts. That's just the body's balance between, hey, I got to run and I'm relaxing. If your body is always kind of in that fight or flight type of phase, you have high sympathetic tone, the heart rate variability will be very tight. The milliseconds will be very similar beat to beat. Right. That is a sign that the body is under significant stress. Now, the heart rate variability score itself is going to depend on what they're looking at. There's different ways to look at these things, the square differentials and, all these, is it low frequency power, blah, 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 blah.
Right.
Just find whatever way that they're measuring with the device that you're using and get your own baseline over like 7 to 10 days before you start freaking out what the numbers mean. Then after like 7 to 10 days, then start looking for your trends. If your heart rate variability is going down below your trend, 20%, look at your environment. Are you eating too late? Are you drinking more alcohol than normal? When we were in Vegas, I tried to stay on St. Louis time, but my heart rate variability was horrible when I travel, westbound. So I was like, that was expected. So you can use heart rate variability as kind of like a check engine light. If you see it going down, audit your environment. Maybe you're getting sick. Maybe you push the gym too hard the day before. It doesn't mean you should just like take a complete rest day, but maybe that's not the day to go do an interval training. Like maybe do something a little bit less intense that day.
Do you trust the Oura Ring's HRV?
Relatively.
Okay.
But it's one of the things where it's like, I should actually be a caveat, and I might be speaking out of turn. It's not actually measuring heart rate variability. It's measuring the pulse wave velocities beat to beat difference. Okay. And so to truly measure your heart rate variability, you have to use a chest strap. You have to be able to measure the RR interval coming off the heart.
Right. I used semaglutide for about 7 months, and I stopped wearing the Oura ring because it bothered me, because there's an increase in your heart rate, your baseline heart rate, when you're on semaglutide, and it kept telling me that my readiness score was bad, so I just stopped wearing it. Can we talk about palpitations and perimenopause?
They're very common. Yeah.
So how can we treat them? Is there any trick besides just BHRT?
That helps many women. When estrogen or progesterone low, they tend to have more premature atrial contractions or premature ventricular contractions. Those are the most two common, causes of palpitations in perimenopausal, postmenopausal women. But again, it's kind of those cases like, you have to test to know exactly what's going on. So, a 12 lead EKG is really good if you're like, hey, I'm having symptoms right now, then press the button and record it. But, there are devices that women can, buy for about $100. You can get a Cardia device, and it measures 30 seconds of your rhythm strip. And then you can send it to your doctor and they can know what is actually causing the heart rhythm issue. But if you don't have access to that, or, you just don't want to buy it, you can wear a Holter monitor or an event monitor and actually quantify, well, how much premature contractions are you having in a day? What is the burden of it? Then similar stories, I look at lab work to see what are their electrolytes, what is their thyroid function, what is the oxidative stress, their inflammation. If you fix those things, a lot of times these premature contractions go away. Because think of the atria is just a sensor. It's sensing everything that's floating through the blood. So if there's high inflammation in the blood, the atria are going to sense that, and that causes them to prematurely fire. So you can kind of do a kind of deep dive in the blood work. Sometimes, it is a hormonal issue. Tweak the hormones and see, does it improve it?
I wonder if, because, as an anesthesiologist, when I first started in residency, I didn't realize how many people throw PVCs, and they don't even know it. Right. So I wonder if the people that are having asymptomatic premature ventricular contractions, that's PVCs, for the people that don't know all of our medical jargon. I wonder how many of those that are just walking around with PVCs that they don't even know, and then perimenopause hits, and those are possibly the ones that have the more intense arrhythmias that they are experiencing from the stage of life. So, all right. So are there any other, because we've got so many questions, but I want to respect your time. Are there any other big things that you want to make sure that our audience hears before we wrap this up? And of course, we'll let them know where we can find you.
So I first just want to thank you for the opportunity. This is a great conversation. Those are some great questions. It's always great when I can kind of meet a like-minded person in real life and then share with their audience that, your cardiovascular health is the most important thing that you can kind of monitor, because it's still, unfortunately, the number one thing that kills people early. And men are sometimes aware of that, but often women.
No, they're more afraid of breast cancer, but
they're always afraid of breast cancer, which
way more.
They're very concerned about breast cancer, and breast cancer is no joke. But that's 1 in 8, 1 in 9 women, where it's 1 in 2 women will have cardiovascular disease that takes them out. So you have to focus on your cardiovascular health.
Yes.
The good thing is that most of the stuff is either free or very low cost. You just have to get the right testing to know where you're falling on that pathway. If you're low risk, great, what you're doing is working for you. But if you're higher risk, there's a lot of things you can do to kind of back that risk up before you have an event.
Awesome. Awesome. And this is when Western medicine actually is needed for some people, but diet, lifestyle, all of the things really are so important. So, all right, Dr. Twyman, I appreciate you so much. It was such a pleasure. I have a feeling that this is probably going to be part 1, because I'm going to get a lot of questions. So I might have to bring you back and do a part 2. Where can my audience find you?
I'd be happy to come back for part 2 anytime. So if people are interested in following me, I am on social media a little bit.
A little bit.
Yeah. I'm not actively trying to grow it as much as I probably need to, but that is the goal. I'm on Instagram. It's just Dr. Twyman's my handle. I do have a YouTube channel where I'm starting to put out some more long form videos. I do have a recent video where I kind of go through my, breakdown of my own labs, how I interpret them, what I'm thinking about on these labs, just basically how a cardiologist interprets his labs. And then I do, see patients in my office here in St. Louis.
Right.
My website, drtwyman.com. There's, a whole host of information about products I use. There's an application if people are interested in working with us. One of the people from my team would reach out to you if you're interested in that.
How far out are you booked right now? If I wanted to send my dad to you.
It's kind of the beginning part of September.
Okay. All right. All right. Maybe we can we can do part 2 because I'm definitely coming down to St. Louis to see both you and Amy Stuttle. So maybe we can do interpret my labs as part 2 as a interactive kind of teaching episode,
Awesome.
because I love that. So thank you so much for your time, your energy, your wisdom, your knowledge. Holy crap, you're truly one of the smartest individuals that I have met in this space. So I appreciate you so much. And for the listeners, if this was helpful to you, make sure that you share it with your loved ones, because like he said, cardiovascular disease takes so many of us way too early in life, and it can be prevented. So thank you very much for your time. I appreciate you, and I will see you next time. All right.
Wow, we've reached the end. But before we leave you, we'd love to hear from you. After all, it's not every day that someone reaches out and asks for your opinion. And to us, your opinion does matter.
Now, the content in this episode is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition.
Share this episode with anyone you think needs to hear this message. And please remember to do your part of the bargain by rating, reviewing, and subscribing wherever you listen to the Made Fitz show.
We are Melissa and Dr. Fitz, and until next time, thank you for your time, support, and action you take in your own health journey. You get one life. Let's live it abundantly together.